telephone. So, and then this brings us to the expert who has done this for last 35 years, and we are trying to learn from the expert that what we can do and how we can accept, to what extent we can accept, and to accept this in our system, and then we can go ahead and bring some relief or some kind of benefit to our patients who are actually in need of telemedicine. So to begin with, I'll just introduce my group here. I have with me Professor Pradeep Saxena. He is the HOD of surgery. I'll just request her to wave so that she can, Ms. Wheeler can identify. I have Dr. Bhavna Dhingra. She's heading the pediatric department here. I have Professor Arun Konkne sir here. He is the community and family medicine professor and head here. And Dr. Vikas Gupta, he's the ENT guy here, is associate professor in ENT here. I have Dr. Sanjeev Kumar. He's he's another CFM family physician person here. I have Dr. Manoj Nagar here. He's basically an orthopedician, but he has exposure and he has worked in trauma and emergency medicine. I have my technical staff also sitting here. I have the person who's actually sitting here and managing the telephone calls, Dr. Ankit here also. He'll be getting his training later on. To introduce Ms. Wheeler, she has specifically asked me not to waste time in introducing her. She asked me to put a paper, if at all I want to introduce her to the people. So Ms. Wheeler has almost 35 to 40 years experience in Teletriage. She has written several books and she has extensively researched and published in Teletriage, and she has gracefully agreed to help us in developing telephone triage guidelines. She refrains from using the term protocol. She wants it to be guidelines, and she has agreed to help us in developing the protocol guidelines for Hindi speaking belt of Central India. And here she is. Now over to you, Ms. Wheeler.
Thank you, Dr. Halder, and I'm so honored to be asked to do this, and thank you for asking me. And I also have to say I'm a little intimidated. I don't get to teach physicians too often. I did do a group down near UCLA, and I think that time frame was even shorter than this one. So it's a lot of material, and I have a couple of caveats, a little disclaimer or two before we begin. That is that this is a very controversial field. I used to say that telephone triage was in its infancy when I first started this, and now I say it's in its adolescence. And the reason why I say that is because it's having an identity crisis, and there are different forces that are fighting over the direction that telephone triage should go in, and some of those are commercial. It's awful to think about, but that those forces should take precedence over medicine and healthcare. But sometimes I think that, and when I'm dealing with malpractice cases, it's often more about saving money than it is about being safe. And so it is considered, and nobody has proven this authoritatively, that telephone triage saves money for an institution by reducing inappropriate office and emergency department visits. No one's proven that definitively. It's a hard study to do, I understand. But people believe that substituting a phone visit for an office visit is always a little, is cheaper. And so that's one of the reasons why telephone triage has come into being in the world at large. It's thought to help save money for the medical industry. It is fraught with some controversy. The terminology is still settling. Telehealth, telemedicine, teletriage, telephone triage, phone nurse, advice nurse. you name it. They've all been used and thrown around, and I try and define my terms. In today's case, I will use protocol and guideline interchangeably. My understanding is that protocol is a step-by-step, more algorithmic, more rigid approach to a procedure. And I believe that that doesn't work very well for the world of telephone triage because it's all gray. And so we can't operate with black and white tools. So what I suggest is the word guideline, which is, in my mind, it's like having a physician at my elbow, coaching, reminding me of what questions to ask and maybe what follow-up questions of things that I may have once known but might have forgotten. So the guideline prompts the nurse to ask questions that she may have once known to ask but needs reminders because this is a very intense experience when you're on the phone. I call it a 12-track brain. You've got to do so many things in a brief time of between 10 and 15 minutes. You're doing a lot of metacognition and a lot of talking and analyzing all at the same time. So the guidelines are there to help us remember which questions to ask and which advice to give and where to put the symptoms. I consider the guidelines a series of boxes, and the operator or the clinician needs to know which box, after doing a thorough assessment, which box to put the problem in. There's controversy about whether guidelines are decision-making or decision support tools. I believe what we are doing here today is developing a decision support tool. Some believe that guidelines should be decision-making tools, which takes the autonomy away from the clinician. I do not agree with that. I could talk for a while about that, but I won't. But just to differentiate, this guideline that we're talking about today is a pattern recognition versus an algorithmic or automated thinking design. And I believe that nurses are autonomous professionals and not message takers for physicians, which is the old role that we used to be in, where we could not make decisions, but we would take a message, which is, we are very expensive message takers, by the way. And I do not think that's the proper role for us. So we're in pioneering mode today. We have to bear that in mind. This is a new venture here, and that you're starting in India, and I applaud you for doing this. The guidelines that I developed were originally developed for a group of patients at San Jose Valley Medical Center, which is neither here nor there. It's in the Northern California area. It, at the time in '95, it served 1.3 million high-risk, low-literacy, low-income population. So the guidelines were designed for low-income people who didn't have a lot of resources, who didn't have a lot of education, and who spoke at the 5th to 8th grade level, literacy level. I bring that up because no other guidelines were designed that I know of were designed for that specific broad population. At that facility, 35 different languages were spoken. So it was a big challenge to develop them. And we also were asked to develop 3 volumes: birth to 6, which is infant child, 6 to 18, which is school age, and 18 and up. So we developed 3 different customized sets of guidelines, and there are about 40 guidelines in each volume, and I think you have the adult version. I used between 20 and 30 expert level nurses and nurse practitioners to help me develop the content. We used hundreds of gold standard references that were available at the time. We looked at other protocols and we evaluated those, and we used all of that as our raw material for the guidelines that you will see. I bring this up because I think there are very few guidelines that are developed by nurses. They were approved and reviewed by physicians. So I think to me, that seems like a good way to do it, because the nurses are the ones that have to use them. We tried to think of everything that we could. The nurses had expertise in everything from OBGYN to rape crisis to emergency room nurses. I had people from every area, lactation consultant, geriatrics. So we had quite a range of expertise to develop them. Let me just tell you that one of the reasons why I made the guidelines that we're working on today the way that they are is because I've consulted as an expert witness on 35 different malpractice cases over the years, and I'm starting to see patterns of error. And one of the biggest patterns is failing to recognize, and this is the most challenging of issues, failing to recognize early sepsis. And the reason why I'm so big on this is because over half of the cases that I consulted on involved sepsis, and the patient often died. And so we are the front line. Even though many of the calls that we handle are not urgent, or maybe they're, a future appointment or just advice, we always have to be alert to the possibility of sepsis. I think it's something that I have become hyper aware of. So I built that into the guidelines. So that's all I have to say is my disclaimer, and here we go. So the agenda for today, and I can have the first slide. I understand that your population is also a high risk population of young families, the working poor. They have a higher literacy level, 8th to 12th grade, but you deal with a lot of high risk. How about the next one, and make it just the slide without the notes? Yeah. There you go. So the agenda slide. Next, please. Good. You have the high risk of the toxic dumps, crime, substance abuse, domestic abuse. We have a lot of area to cover in our guidelines as well. We will try to cover every bit of this today. And I'm looking forward to, getting to the end where we talk about the guidelines. So next slide. So everybody knows the definition of triage: to assign a degree of urgency to decide the order of treatment for a large number of patients. Well, that's what we're doing in this work as well. But the problem is that we can't see them. We're talking on the phone, and it's hard. It's hard work. It's much easier to do face-to-face triage. So the purpose of telephone triage is to facilitate access. We're there to not be gatekeepers, but to facilitate access for large numbers of people. We're doing a task to help the system run better. It's intended to reduce inappropriate appointments and office visits. However, still historically to this day, and it started informally in 1970s in the United States, it's historically still unsafe. And there are a number of reasons for that, but we're still in early days, and like I said, we're in adolescence, and we have a long way to go. I believe that we cover what we call in the United States, we say We cover chest pain to chicken pox. It's an expression that we use. That means we cover not so serious problems, and sometimes they're serious. So yes, it may be that calls are non-acute and only need advice. However, we need to rule out urgencies first, and that's the most difficult task of all. Patients call for a reason, and they may say, you know, I just need to know what the dosage of aspirin is because my baby is crying and I'm worried about giving her too much aspirin, and I don't know why she's crying, but just tell me the right dose. I don't want to give her too much. The nurse, the clinician needs to back up and find out more about why the baby's crying. And make sure that it's just a call about the dosage of aspirin and not a call about a meningitis or sepsis. So they call for a reason, and there is a study recently that shows that many calls to the emergency room, to the call center, are as serious as an emergency room visit because the patient is reaching out, and these are calls about certain specific symptoms. I think maybe one of them was abdominal pain, but there are certain symptoms that are big red flags that if patients are calling about them, then you need to pay close attention because they may need to go to the ER. And so we will talk about that in a little while. They may be worried and they may not need an appointment, but they're calling because they want to know whether their symptoms need to come in or not, need to be evaluated on site. So that's the real thing, is they're asking you, whether they say it or not, do I need to come in? Is this something that needs to come in? And they may not want to come in, and they may not be able to come in because they have lack of transportation or many things they have to do. They don't have anyone to drive them in, but sometimes we need to convince them to come in. So there's issues with telephone triage that don't arise with other problems and populations as well. Telephone triage is a time-sensitive task. You know the saying, time is tissue, time is muscle. Some here view a telephone visit as a virtual visit. Next slide. This is what I talked about before. I am not a believer in automated reasoning or algorithms for this work. I believe that they break down in the world of telephone triage under the conditions of uncertainty and urgency. Vimla Patel, who is my hero, who started me down this path in one way, she's an expert in medical decision making, and she did one of the first studies of emergency room nurses back in '95. She said triage by phone represents a gray area between medicine and nursing where the medical diagnosis or the differential diagnosis is not essential in order to make a decision about the appropriate intervention, and where the dimension of urgency becomes the primary focus. So next slide. So we are not about differential diagnosis. These are some of the malpractice examples of why malpractice happened. In many cases, first of all, I can tell you that, and this is not important to you because you're not going to be taking calls, but probably the worst thing that someone can do is not talk directly to the patient. I'm not talking about little children. I'm not talking about the elderly that are unable to speak for themselves, but it's really important for nurses or for clinicians to speak directly to the patient, because then they can have a chance of getting the best information possible. But when these are some of them, that was the biggest mistake most people make. The second is they don't do adequate assessments. They fail to consider the patient history. There's a lot of stereotyping. This is fraught with cognitive bias because we can't see the patient. It leads to tons of cognitive bias. And the final one is the other big one, is a failure to communicate. Failure to communicate to the patient or the family and to the other physicians and clinicians. So all of these malpractice cases resulted in delays in care, or delay in treatment, or delay in diagnosis or evaluation. We do not want that to happen. So that's why telephone triage is so time sensitive. The root causes of error are failures of assessment, communication, continuity. That means that somewhere between the time the patient hung up and the time they were actually seen, they fell through the cracks. Human error is cognitive error, and informed consent is a very important feature of telephone triage. We need to communicate well to the patient what the disposition is, and by disposition I mean when they should be seen, where they should be seen, and why. They need to know that in very clear terms so that they follow up, so they comply. And without that, we've failed. We've failed to provide informed consent. And like I said, not everybody needs to come in, but clear instructions about follow-up are critical. Next slide. These are the experts that I have relied upon to develop my materials, most of the elements of the guidelines. Like I said, Bimla Patel, the Institute of Medicine, which in 1999 wrote a big paper called "To Err is Human," and they pointed out the issue of systems error. And they started us, as in the United States, down the path of developing better systems. We try and model ourselves after the airline industry, which has a much better safety record. And Donna Bedian is a physician who stressed that quality is the result of high-quality structure, high-quality process, and then you'll come out with a good outcome. Atul Gawande is a checklist guru. I use him heavily in my world, and there you can consider a guideline, a big, long checklist. Kahneman wrote the book, I think, Thinking Fast and Slow, about the different ways that we solve problems with different approaches in our brains. Baumeister and Tierney talk about decision fatigue, which figures very, very big in the world of telephone triage. Like I said, the clinicians are making decision after decision after decision every 10 minutes or so. And if their tools are not user-friendly, or if there are thousands of different titles that they must wade through, or if they're confusing, or they're conflicting, or they have maybe 8 or 10 different dispositions to choose from, it creates decision fatigue, and that's really bad in our world. Baumeister and Tierney said that after 6 hours, humans they start to have decision fatigue, and they did a study of judges, and they found at the end of 6 hours they were starting to make really bad decisions about their legal opinions and legal decisions. So I pay close attention to that, because this is a very mentally labor-intensive job, and decision fatigue, we do not want to add to that by giving them tools that are hard to use, that make them more exhausted and more that add to the burden of decisions. Wachter is a physician at UC San Francisco who wrote a book on the dangers of over-reliance on technology, and he has some really good points. And then, like I said, my area is to reduce malpractice error So I try to build those into everything that I do, including the guidelines. So I try to use a systems approach to telephone triage and to medical decision making. Next slide. Next. These are, okay, so the system. As an expert witness, when an attorney calls me and says, I have a case and I need you to evaluate it, here is what I ask for. I ask for the qualifications of the person performing the call. I ask for their training materials, how they were trained in telephone triage. I ask for the documentation of the call, and I ask for any policies and procedures or standards. I always ask for those things. And then finally, I ask for the guideline that that clinician used. And that is my evidence of their practice and whether it was safe or not. And in many times still, I'll get a job description, but sketchy training materials for telephone triage, maybe none, maybe a sketchy guideline, sketchy documentation, and maybe standards. So I'm still not seeing evidence of high quality integrated systems that all the parts work together to produce a good outcome. What I believe that many in this industry believe that protocols are the bottom line. I do not believe that. I do not think that's a safe way to think. The bottom line, in my mind, is the qualified, well-trained clinician and who knows how to use good judgment and who's good at making many decisions. They usually, I used to say they should have 5 to 10 years experience. I think it takes 10 years to make an expert. You don't want a new novice graduate to be doing this work because they haven't had enough practice making decision after decision after decision at the bedside. So this is a tool, but it's not the ultimate tool. These guidelines, they are part structure. We are going to design them to be part structure and part process, but they do not take the place of a well-trained clinician, and you cannot just turn a bunch of high school grads loose with the most sophisticated protocol in the world and say, yeah, you can do telephone triage. I am really strong on that. Just because I've seen so many bad outcomes in the form of malpractice. So I really, this is my bias, and these are things that I've seen over the years, 35 years, 35 cases. This is legal tradition. So that's, those things I've listed are an integrated system. So qualified staff, training for the staff, documentation, policies and procedures or standards, and the guidelines. Next slide. So this is the goal. You want all of the above: improved systems, improved safety. Inadequate guidelines can degrade practice, and by the same token, inadequately qualified staff and inadequately trained staff may use quality guidelines improperly. Guidelines do not work well in a vacuum. They require clinical training. So this is all part of a system. Next slide. These are some of the current design flaws. And like I said, we're still making lots of mistakes, even though this field has been around since 1970. This is what I look at. And these are design flaws from current guidelines. These are things that we saw when we developed our guidelines in 1995, and we tried to correct these. But there's still a lot of guidelines out there that have these problems. Next slide. No user's guide. Most of them don't have a user's guide. They're starting to now. But this is something I talked about before, is that you claim to be a decision support tool, but in fact your guideline acts like a decision-making tool. And that's what I think comes of the algorithmic differential diagnosis approach. I don't think it works well in our world. Less is more. Hundreds and hundreds of protocols will only increase the burden of the user. And so I tried to create protocols that were, well, I tried to make them reflect the way the patient might present the problem, and they don't know what the problem is. They just say, I have a headache, or my ear hurts, or there's something in my eye is all red. So the reason why you'll see that, you probably have seen the table of contents, the reason why I did them the way I did was to reflect the incoming calls and to reflect how patients might present them. And that is, usually it's site-based. Yes, they may present as a symptom as well. I'm having nausea and vomiting, but they often present with, I hurt my ankle or my legs are swollen. So what I did with my guidelines that we developed was I made them site-based. So the ear problem has everything that can happen to an ear in it, whether it be trauma, foreign body, pain, discharge, ringing, hearing problem, anything that could happen to an ear is in the ear problem protocol. And that's a really big difference from all the other protocols. And that was to, I think unconsciously at the time, to simplify the work, the search feature of trying to find the right protocol, which is a real problem. If you have hundreds of titles, it will really be frustrating for the user. So that's why I say less is more. And you can do whatever, you're going to do what you want with what you have. But I'm telling you from the user's perspective, trying to sort through a list of oddly labeled symptoms and trying to figure out which one is the right one, it's very burdensome. So that's one of my other caveats, is that, and some people think that more is better, but they don't have to use them. They don't have to deal on the line with them. And so that's why I feel that we have to consider the user. And decision fatigue is a big problem. It leads to burnout. So anyway, most of these guideline software, paper, they have no clinical training for the task of telephone triage, for the decision making and critical thinking. They do not have any formal training. They have software training, but that's not the same as clinical training. And that is really, really important in this work. There's a lot to know. So that is, to me, is a big problem. And then many of these guidelines have no triage feature. And you'll see that momentarily. They don't triage. I don't know how to explain it other than to show you. So next slide. Okay, so let's back up a little bit here. Why are we doing this? Because we have a legal duty There is an implied relationship. The moment we pick up the phone and answer it, we have created a relationship to the patient. We have a duty of due care, and the standard for nurses is, what would a reasonable, prudent nurse do under the same or similar circumstances? One of our major duties is to communicate significant information to the patient and to the physicians and to the other clinicians. And because it is a virtual visit, it means we still have to adhere to the same standards as face-to-face encounters. Our practice is supported by guidelines, and therefore, these tools must support us in performing the task in a reasonable, prudent manner. So that our tools must be reasonable and prudent. Next slide. These are the standards that inform the guideline design that I have created. They should be valid, meaning if they are followed, they will lead to expected outcomes, and reliability, reproducible. Given the same data, other groups of nurses would produce the same results. They should explicitly state the populations to which they apply. I have done that. I've clearly outlined the birth to 6 group, and they're different. The 6 to 18 group, school age, they have the same basic guidelines, but there are differences, and the adult. So that's really important. They need to be flexible. They should have a user's guide that explains what the exceptions to recommendations and the rules or provisions for situations that don't fall into a typical presentation. There should be clarity. There should be unambiguous language, precisely defined classifications and definitions, precisely defined terms, user-friendly and easy to follow mode of presentation, and they should be transparent. That's the problem with software. You cannot see what you're dealing with. The beauty part of a book is it's transparent. You know what you're getting. You know you can follow it. You can see the reasoning on paper. But with software, you're sort of lost behind, it's back there somewhere. And so it's not as easy to know how it's working or why it's doing what it's doing. And I think that, in fact, books of guidelines are, they're pretty good. I think the software is still getting there, but transparency is really important in this world of telephone triage, and that's what we're trying to accomplish with our guidelines. Next slide. Okay, now this is an example of dispositions from a given guideline. And at first, when you look at them, you think, well, they're specific. Consult the emergency physician, or go to ED now, but we don't know what now means, and I'll tell you why that's not a good instructions for the patient. Go to the office now, see within 24 hours by appointment. These are not representative, in my mind, of outcomes for a telephone triage system. There's no acuity, urgency level. It's not divided into 3 levels. They're very deterministic. They're very specific. And this is kind of hard to explain, but one of the problems that I have with most guidelines is they only operate during office hours. And as you know, and I don't know how your system will work if you'll have after hours, but office hours is 40 hours long. After hours is 3 times that from 5 in the afternoon until 9 the next morning, all day Saturday, all day Sunday, all day holidays. So these two will break down after hours. So you need to create boxes with labels that are flexible enough to accommodate a 24/7, 365 symptom presentation. Eventually, you will get there. Maybe you will start with office hours only and then everything goes to the ER after that. But that is not, supposedly, is not a very good way to manage calls after hours. So this is a set of dispositions for one call. Those are the options the nurses have. There are 8 of them. But they don't represent, in my mind, they don't represent triage. Okay, so next slide. This is what I'm proposing. You will modify this in the future. You will work with it. And it's very different from the one that you just saw. But it is triage, 3 levels. It is explicit in its directives to the patient. And why do I hammer on this so much? I'm going to give you an example. This was given to me by an attorney who knew of this case. Young childbearing age woman had severe abdominal pain at home. She called the ambulance. They came, they examined her. They decided she didn't need to be seen. They left. The pain returned. Her husband called the emergency room nurse and said, "What should we do? My wife is having this terrible abdominal pain. What should we do?" And her advice was, "Come to the emergency room." That was it. And even though it sounds like safe advice, it really wasn't. Because what happened was the caller hung up and they didn't come right away. They didn't know, they weren't advised to come emergently. But they did take some time, and then when they finally showed up, the patient was in dire straits. And she ended up dying, exsanguinating from a ruptured ectopic pregnancy. So when it went to court, the judge said, well, he gave blame to everyone. The paramedics were wrong for leaving. They should have brought her in. The patient herself should have probably taken some responsibility too. But the person who was talking to the advice nurse, he should have come in sooner, but the real culprit was the emergency room nurse. And her failure was the failure to apprise the caller of the seriousness of the situation. The only way I know to do that is to be very, very explicit in my instructions and disposition. So if I say, well, come to ER, some people know that if they come to the emergency room, there's going to be a long line because emergency rooms here are overcrowded. And they don't want to come. And so they won't follow through. They won't be compliant. But if I say, after what you've told me, your symptoms sound like they could even be if they were life-threatening, I would advise them to call 911. But if I want them to come to the ER, your symptoms sound emergent. Can someone drive you in safely within the next half hour? Yes or no? And they say, yes, my husband can drive me in. Okay. Now, I want you to be in the emergency room in the next half hour. Will you do that? Yes or no? Yes, I will. Okay, so you've created a contract with the patient. I just think, these are worst case scenarios where patients fell through the cracks. That was a continuity issue. The patient died because of delay in care. And so this is a way to prevent that from happening. We need to be very explicit in our instructions, and we need to use the concept of triage rather than just dispositions that are, 8 in number. So this is why I feel so strongly about the disposition being a place. This is where I want you to come, whatever is open appropriately at whatever hour. This is when I want you to come, and you have time frames that are flexible so the nurse can use their judgment. And they can override and upgrade if they wish. They should not downgrade without a physician's input. But these are the time frames within which the nurse can operate. The first one is urgent. The second one is a same next day appointment. And the third level is a future appointment or advice only. So these are the levels that we can work with. And excuse me. And then why? So where I want you to be seen, when I want you to be seen, and why is because your symptoms sound emergent or because your symptoms are not acute. So what you've told me sounds not serious, and here is my advice for home treatment. You're giving a rationale, a reason, and a place and a time for the patient to be. You can manage these at home over the next 24 hours. I want you to call me back after that. I want you to call me if your symptoms change and new symptoms appear, because if your symptoms change, my advice will change. So those are the kinds of things that we're doing on the phone, and this is the tool that helps us to do that. And like I said, this will be modified, but this is a triage tool, and these are dispositions for 3 levels. Okay, next slide.
Miss Wheeler, I'll just add few things, just a word here.
Yes.
The Institute of Medicine, according to the risk stratification, they divide the risk into 5 categories. And
Right.
And the way Miss Wheeler has been doing is to have 5 different types of dispositions, what they have been using. Like first is an life-threatening emergency, and they used to call 911. The second was an urgent symptom, so it is the patient is asked to report to the emergency department within 3 hours. If I am wrong, Miss, please correct me if I'm wrong. But what we in the discussion found that we may not be able to differentiate between calling an ambulance and then the person going by himself, because the ambulance system, the transportation, the medical emergency transportation may not be as robust as so what we have tried to bring it down from 5 to 3, because we didn't see any sense in differentiating the emergent and life-threatening system. So this is a modification, and this is probably a major modification from what Miss Wheeler is doing. So and she has
and I'm okay with that. I mean, it has to reflect reality. And you described your patient population as not having transportation or not having ambulances, and you have rural situations. So I mean, we have to be realistic. So you do the best with what you've got, but you still have a system, So I'm good with 3 levels, as long as they're defined.
So since sorry for interrupting. Since I had that question in mind when I began reading those 5-tier system, so I just wanted to inform this to my friends here, that when they read somewhere, they may find it in a different form. And this is a little different. So this is something which we have adapted to our system.
Exactly. As it should
Please
be.
carry on.
Next slide. Next slide, yeah. Okay. So think of the guidelines as tools to rule out urgencies, or maybe to rule in non-acute. So I thought this was a brilliant statement. It is much easier to identify an emergency than to rule one out. An average layperson can see when somebody's really sick or having a heart attack, or most of the time it's very apparent, and that's obvious. Those are the no-brainers. Emergencies, in my mind, true emergencies, are no-brainers. It's so obvious, it calls attention to itself. You don't have to think too much except how fast to get them in or what first aid to administer. The hard part in our world is ruling out emergencies, and that's what the guidelines help us to do. So because of all of these malpractice cases, I try to not only build a system that is triage-based and that has a descending order of acuity. In other words, it starts with the most emergent and goes down to the least acute. But I also try to build in screens, checklists, and rule-outs. And the reason was that like I said, I do believe we need to be doing sepsis screens to rule out, dehydration screens to rule out those scenes, and we also need to pay attention to patients who are high risk and symptoms who are high risk, so we can make sure that those are not falling through the cracks. Next slide. The next one would be the built-in checklists, which you'll see, I think you'll see it in the guideline. And this is a Atul Gawande thing, and you know, I cannot say enough for his approach, you know. He is a surgeon, and I believe he started the checklist for surgery to help make it safer. And you think, well, how difficult can that be? But apparently things happen a lot. So, but he says, you know, what, for instance, are vital signs that every hospital records, if not some kind of checklist, and it gives us a picture. So I'm a big believer in what he is promoting. And so I tried to include checklists of sorts into the guideline, into the universal guideline, and also into some of the specific guidelines. So you will see examples of that. Next slide. Finally, the content. Like I said, this is intense mental labor in a very short time. So, for instance, as a user of the guidelines, if I have to translate medicalese to lay language and then translate that from college level to 5th to 8th grade level, it's taxing. Patients won't comply with instructions they don't understand. We need to bring them to their level. So I recommend 5th to 8th grade because I think it's the best level to use anyway for this type of task. And I think that instructions should be very short with the imperative voice. And the reason why we do this is we tell them why they're going to take the aspirin to motivate them, what it will do, what to expect, how to carry out a home treatment, and when to call back or come in. Okay, next slide. So the universal guideline, I came up with this originally. It was the template. In the early days, we had a template that we used for building all the guidelines. And that was the original purpose. And we plugged in a lot of the standard screens and Ruleouts. But now it has evolved into something more where, and the other problem is that the nurses doing this work find that they often they can't find the right guideline. So what do? Do you use no guideline? Or do you use the fallback? And the fallback is the universal guideline. So when you can't find the right one, you go to the universal guideline. So that was the second use of it. But now I see it as a possible preemptive guideline that could be used initially before using specific guidelines like the burn protocol or something. And I also see it as a home base for training new staff because it contains, if you took the boxes away, it would amount to policies and procedures for handling different kinds of calls. So if you removed the framework, the lines, and just put them on paper as a training tool for new staff, and you would see that, oh, this is a good training tool. It could also be used for face-to-face triage in the emergency room, clinic, or urgent care, or office. So I see the universal guideline as in a new way, and I think it could be a very useful tool to you all if you choose to use it. Next slide. My recommendation is that you start with the most common symptoms. Here in the States, this is a recent study of the kinds of problems that present in the emergency room. It's not surprising. These are often the same symptoms that are underdiagnosed and wind up in malpractice cases. What are the 3 top underdiagnosed conditions? Ectopic pregnancy, appendicitis, and myocardial infarct. At least that may be old research. I would say sepsis. I would add to that sepsis because I think that it is underdiagnosed. But a lot of those diagnoses have these symptoms: abdominal pain, shortness of breath, chest pain, back symptoms. So they're subtle and they can be kind of problematic, these diagnoses. So, but I think that if people call about abdominal pain, we need to pay close attention. It's a red flag. And these are, I think, the ones that need to be ruled out most quickly because they're so life-threatening at times, not always. So the next slide is your top 10. And what I did is I went through your list of frequencies. Next slide. I saw that there were 257 calls for an unclassified protocol, and I wasn't sure what that meant. Dr. Halder, what is that? Unclassified protocol.
Actually, this is the whole list we came up when we analyzed the phone calls from last almost 3 years, and they were actually not classified.
I see. Okay.
We went back and did the classification again and tried to bring out some kind of uniformity while referring to some a usual one of the protocol books. So these complaints, we could not find any group where to club these. So this is our own name which we have given to be very true.
I was thinking that they were calls that they couldn't find a protocol for. So that's what was my interpretation.
In other words, in other words, it is the case where we could not find any protocol. We could not find any protocol.
So that matches nicely with the concept of the universal guideline, because that can meet those needs. So interestingly, skin problems, when you lump them all together, including, lumps, bumps, and itching, bites of all kinds, and burns, those are the highest categories. followed by head problems, abdomen, respiratory, and so forth. So this list is not that different from the list that I had. So I kind of wanted to point that out, that, you know, there are similarities, and these are sort of pointing us in the direction of the first guidelines that we need to develop are the calls that come in most frequently, and this is an example of that. So I'm going to take this slide, this away for the moment, and we should look at, you know what, would it be possible for you to put up the flow chart, that the revised flow chart? I forgot about that. You know, the one?
Miss Wheeler,
From your end,
I'm sorry,
you know,
I didn't. Miss Wheeler, sorry, I didn't. Put up that revised flowchart. I was not very sure, so I thought that we'll.
Bring that. Okay.
Yeah, I will do it after the meeting. This meeting, and then consulting everybody. So I was not very sure.
Okay.
So
all right.
I didn't
so it's not ready.
get it.
Okay.
Made, yeah.
So let's look at the universal guideline. Okay. So, so here we have a very modified, oh no, this is the wrong one. Oops, sorry. This is an old one that I don't want to use. Let's see.
The participants here have a copy of universal guideline. So if you want us to put it on screen, then that we can do.
Okay, maybe you should do that then. That would be better. If you do that, and then I can talk about it, because we're going to illustrate how all this is coming together in the guideline. So, okay. So it's coming, yeah. Are you waiting for me? I can't hear you.
Yeah, am I audible now? Am I audible now? Am I audible now?
Yes.
Yeah, I was just requesting that we can continue with the discussion by the time Mr. Asif puts up the guidelines on screen. All the participants has they have the copy of the guideline with them, a printed copy.
Okay. Well, all right. So I'll go to mine, and maybe we can talk about. I'd love to hear some feedback from the class. Anything you want to say?
So anything specific you want to ask, I can pass on the mic to the participants if you want to ask.
It's a little faint. No comments? So are you looking at your universal guideline? Everybody?
Yeah, all the participants.
If you don't have questions.
A printed copy with them.
Okay, so looking at the universal guideline and scrolling down, you will see the obvious emergencies. And do you see where it says suspected or confirmed infection and any sudden change in mental state or confusion, abdominal pain? So, any thoughts or observations about this? This is where I plugged in sepsis and dehydration. I believe that severe pain requires evaluation. I believe that emergent symptoms need to be ruled out. So these are all life-threatening or emergent symptoms that need to be dealt with in a timely way, very quickly. If you look at, I'm just going to pull up the other slide because I think it's too important to see what I'm talking about. Whoops. Just know this is not the one that you have, but it's a version.
So,
okay.
I have a feedback.
So can you see this?
I have a feedback from my pediatrician colleague is that we don't find the convulsions here. So where do we club the convulsions?
Convulsions. That's a really good point. I think it's here under decompensation or threat of decompensation of vital functions. So that would be neurological. It's a very generic description. But you're right, seizures should be here. That's a good point. Can you see what I'm showing you on my screen? Or not? Can you see this?
We cannot see your screen. We cannot see your screen.
You can see my screen with this guideline on it?
No, we are not able to see your screen. Yeah. Are you able to share it now?
I think I need you. Oh, this is the same problem we had before. Let's see.
We are almost ready with the
have it?
Yeah, we'll pull it up on the screen. Just
Please,
another few seconds.
Okay. It's just easier if I point to things when I'm talking about them because I think I don't know what you're looking at on your paper. But and that last guideline, I think it was missing OBGYN emergencies as well. So your version has that, but you can tell as you do different versions of these guidelines over and over and over again, sometimes things fall off the page and get lost. So do you have any comments or questions about what I've said so far? Anyone?
I'll request participants if there's anything anybody wants to ask or want to add.
Hello. Yes, ma'am. How difficult is it to train the newcomers? I mean to say, can you train your experience to a completely newcomer to effectively use the Tele-triage?
Newcomer meaning novice practitioner, novice clinician?
Yes. Yes.
Is that what you mean?
Yes.
I don't recommend it. I think it's really hard work mentally, and you need to have experience. I would say 3 to 5 years. I would recommend nurses myself. I think it's a dangerous proposition to use new people, new. What were you thinking of? Like a resident, physician? Were you going to use nurses or doctors? I forgot.
Okay.
Do you? Oh, does that answer your question?
So I think, Ms. Wheeler, you can see the guidelines on your screen.
There we are. Okay, great.
Yeah.
This is the what I wanted to see. So, right now, let's get this out of the way. You can see the draft.
Ms. Wheeler, I'll just transfer the phone to my pediatrician colleague here, Dr. Bhavna. She wants to ask a question regarding this.
Hi, we have put shock or impending shock as a separate head and decompensation or threat of decompensation of vital functions, wherein we have included circulation as a part of it, as a subheading.
Mhm.
So how is shock or impending shock separate from this decompensation?
That's a flaw. That's a flaw. You've picked out a mistake. Yeah, and that needs to be fixed. I think that in doing this, we tried to capture all emergent situations, and that there is redundancy there for sure. I mean, loss of consciousness would be considered a neurological, crisis. So yeah, you've seen that there is imperfection here, and like I said, we're still in pioneering mode, and I think there is work to be done even on this. So definitely.
Thank you.
I mean, each of these represents a certain picture, but they could all be lumped into that same category. For some reason, I'm not able to move this anymore. Is there, or go through it? Can we scroll down a little bit so I can see the rest of the guideline
Yeah.
a little bit more?
Yeah.
Can you scroll?
I'll have to do that.
There.
I'll have to do
So
that.
this captures a lot right there, and I adapted that from the ACEP, the American College of Emergency Physicians. I think that's one of their definitions of an emergency. So I plugged that in, but here are more a kind of a broken down version of this. So, like I said, we're still working to perfect it. But the point I'm trying to make is here's the suspect sepsis part. And these are hard things to determine over the phone. But sometimes you can get the patient to help you with this and to do their own self-assessment and tell you what they're seeing. And can you scroll down a little more? So that's to rule out sepsis. That's more subtle than one of the other ones. And here's another one to rule out dehydration. And scroll down, please. A little more, scroll. A little, yeah, keep going. So here, I give the nurse or the clinician the liberty to decide if there is any situation where there's severe pain or suspicious or emergent symptoms that need to be ruled out, that can be brought in emergently. So that is a very broad description that relies on the nurse's or the clinician's opinion. So this could scroll down. This is trauma that relates to possible domestic abuse. Scrolling down, and here again, I'm so worried about sepsis, and maybe I'm over worried, but because I believe that we are the front line that might be able to pick it up in its more subtle state, I put in, these are parameters that were created by an authoritative group. I mean, this is the latest information on the parameters that qualify for sepsis. And again, it's hard to get heart rates and it's hard to get respiratory rates. But with these new medical apps, and I don't know how prevalent they are in India, but you might be able to get a heart rate, you might be able to get a respiratory rate, you might be able to determine that, the temperature, really important. But then you need to factor in, and this is the checklist that I was referring to, who is the patient we're talking about? Are they immunodeficient? Do they have immunosuppression? Are they taking any medications that make them immunosuppressed? And so on. Because these are often postpartum, big problem, antibiotic therapy, MRSA, alcohol and substance abuse. These are all related or risk factors for sepsis. So I put those in there as a checklist to remind the nurse or the clinician what things to know and ask about. Keep scrolling down. Scroll, yeah, a little more, all the way to, yeah. And here again, pain and unusual symptoms and any fever or postpartum or procedures. So pain and these situations are also a setup for sepsis. I may have gone overboard, but I'd rather do that than not. Scroll down. And then possible exposures. These are situations where you've got adverse drug reactions or drug disease, drug-food interactions, and or any intentional accidental ingestions or exposures. And then this definition comes from ACEP. And it's hard to, you probably deal with this a lot. So I think that you have to be thinking in this way. Would this situation possibly end up in the ER within 24 hours? So scroll down. So those are all emergent or urgent situations. To the next complete page, yeah, all the way. Okay. These are moderate symptoms. This is a very generic description, but I left that there because I think that high-risk patients present problems and you need to know that you can upgrade them. Emotional stress may take the form of multiple phone calls. This is a study I would like to do, and it happens a lot in these malpractice cases, is that the family is called multiple times. That's a sign of emotional distress. No one's paying attention to that. Frequent phone calls should be considered a major red flag. This is an important feature of, this is another checklist that makes the patient high risk who has moderate symptoms. You might want to bring them in tomorrow as opposed to letting them stay at home. Scroll down, please. So those are acute levels patterns. And this is minor. Self-limiting, not becoming markedly worse, improving on home treatment. And then I have a rule of thumb to assess all children and elderly. These are some more rule outs. Can you scroll down a little bit? A little more scrolling. Yeah. These are standard ER rule outs, and I think they're valid for our work as well. And keep going. Scroll a little more. Yeah. So wait. So these things are all things that are ruled out in the emergency room upon initial encounter. I think they should be part of ours as well. Maybe it's overkill, like I said, but it can't hurt. So this is more. This stuff is an explanation of the the 3-level triage that we talked about earlier. So why don't we look at the burn protocol? And do you have that online that you can pull up, the burn? Or do you have any questions? First of all, do you have any questions about this guideline? And again, I know I'm giving you a lot at one time, but okay.
So we can proceed with the burn protocol. Yeah.
Okay. So can you scroll up a little bit? Yeah. So here again is the same approach, but not modified for your needs. But the point is, we've got all burns in one guideline. It simplifies the search and the process for the user. So electrical, let's go back a little bit. Scroll down just a tiny bit. Down, I mean up. I'm sorry, up. Up the other way. Yeah. Little more. I just want to see the title. So here's what I'm saying is that less is more. I have all types of burns enclosed in one guideline. So the nurse knows, well, it's a burn. I know which guideline to go to. Whereas if it's divided into 7 different guidelines, it's more problematic. So there's 3 kinds of burns, and here they are. And I think sunburn is part 2. So these are all the serious burns, and then sunburn comes secondly. It's also here. So the electrical burns, you see the description of it. And let me just say that, do you all know what the Merck manual is? Do you use that at all in India, the Merck manual? Does anybody?
Sorry, Ms. Wheeler, what was the question?
Have you ever heard of the Merck manual, MERCK? It's a drug company, Merck manual.
Yeah.
Okay.
But
So,
she's talking
yes, you have it there?
Merck manual. Yeah, one of few of our friends use that. Yeah.
Okay. So
Not
that
me.
is a collection. It's a major reference. It's updated frequently. And what it contains are the classic pictures of thousands of disease conditions. So I use the Merck manual as my model for my guidelines. In other words, but we tried to create the classic pictures of certain conditions that were life-threatening and some that were frequently presented, and some that were not life-threatening but were frequently encountered, to create the body or the content for the guidelines. So I'm just telling you that was what I had in mind. But the Merck manual is it's hundreds of pages. And we don't have time on the phone to go through hundreds of pages. So what I tried to do was to create a more streamlined version of the Merck manual, which is a medical reference. This is a medical reference of a sort to be used. It's a working tool to be used in a quick way. It's a quick reference. And so that was my model when I originally conceived of the guidelines. So you can scroll down and you can see all different kinds of burns, thermal, electrical. You can scroll down. And there you can see some advice or some warnings. Here is how to estimate the, and there are typos on this page, excuse me, and I apologize. There are some typos, so please disregard them. But here we have the descending order of urgency, starting with the most serious and going down. Keep scrolling. These are urgent level. Scroll. Okay, and here I have a cross-reference, and that's abuse. Scroll down, or, child abuse, elder abuse. Keep going. More. It should be part 2. here we go. Wait. Here's part 2, which is sunburn. And there's, the most emergent one is possible heat exposure. Scroll down. You can scroll. Here are the urgent symptoms, and then the non-acute sunburn, and then the cross-reference. Scroll down more. And these are the first aid or home treatment. So here we have a quick reference that lists the first aid for different types of burns. Scroll down. Scroll down a little. Can you scroll, or can you hear me?
Yeah, we can hear you, and that was the end of the burn protocol. 5 pages. The
Oh,
fifth
but
page.
don't you see what I see? Wait.
It is the 5th page.
There should be some home treatment instructions.
This is the 5th page. I think I moved too quickly.
Maybe scroll back up. I don't know. I can't do it. Are you scrolling or?
Sorry, it was not there. The home treatment part is not there.
Yeah, it should be.
I think we have seen 5 pages. All the 5 pages. 2nd page.
There should be more. Yeah.
3rd page.
I can't see what you're seeing though.
4th page. First aid. Is that the thing?
Yeah, but I can't see what you're seeing on my screen somehow.
Screen share. Oh, but our screen is showing that we are sharing our screen with you.
But I have a blank page in front of me. I don't know.
We'll do it again. We'll do it again. Let's see.
Okay.
Can you see it now?
I see your logo. It's starting, I think.
There must be some network issue.
So,
Can you see something now?
no.
Is your internet working there?
Yeah, it should be. Yeah, I mean, I can see you all, so I know we're connected, but I cannot, and I'll see your logo, but it's just seems to be stuck. The logo is all I can see for your.
Okay. So should I try and put up the slides again, the PowerPoint presentation?
Well, let's look at the burn protocol because
Okay. Okay.
I want
We'll
to
check it.
continue.
We'll check it again. Let's see why it's not working. We'll do
Okay.
it again.
All right.
Any change? Can you see anything?
No, it's just going to your logo. Well, the point I'm trying to make is that the skin problems, the burn protocol, the instructions we tried to create instructions that were at the 5th to 8th grade level. So if you look at the first aid for a thermal burn, you'll see that some instructions there. An SA means, just look at your paper version for now. Instructions for the patient on how to estimate the amount of the burn. So it's very specific. They're meant to be read directly to the patient, so the nurse should not have to do any translating of college level to 5th to 8th grade. So you say to the patient now, using one palm of the victim's hand, only the palm, that is 1%. So how much area is burned using the palm of the victim's hand? So if it's a child, use the child's hand. And then you tell them if the clothing sticks to the skin, do not remove the clothing. Put the burned area in water, cool tap water, for no more than 3 minutes. So these are specific instructions for a burn that are in lay language, that are meant to be read and quickly carried out, of things to do and not to do. So scrolling down on the burn guideline, it includes instructions first aid for chemical burns, and then assess the burn, and then the care. The reason why they're taking Tylenol is to reduce the pain. You could use cold compresses 4 times a day. These are all the kinds of instructions. So they're not lengthy. They're not at college level. They're very short and sweet, so they will be easily understood and carried out. So those are the instructions, which I think are important if you're doing a lot of home treatment and so forth. So do you have any questions about that?
We'll proceed, Miss Wheeler. Am I audible? Your screen is stuck.
Yes, it is. I don't know why. It's just doing what it does.
Am I audible to you?
Yeah, you're audible. I just clicked you instead, so now I see you better.
Okay.
Can you see me?
Yeah, I mean I can hear you, but your screen is not moving. So we're trying to see.
You cannot see me moving.
Yeah, it's stuck at one point.
Well, the joys of technology. I would love to have more feedback from anyone about how these could be used for your purposes.
What my technical person is suggesting, that your CPU utilization must be too high. So probably if we can close few of the windows, then that will help probably. If any other window which is not used can be closed.
I don't think there's any other window open on this computer.
So should we go to the PowerPoint now?
If you want, sure.
Okay.
I mean, we're done with that.
Yeah, that's why I said it was 5th page.
We can
Yeah.
talk about it some more if you'd like. Yeah.
Can you see the PowerPoint on your screen?
No. This here is just going around and around. I can't. I cannot make it work. So
Miss Wheeler, we can continue from slide number 15.
Number 15. Mm-hmm.
Yeah, so we have the 15 slide on our screen, and you can continue. When you ask us to change, we'll change.
Okay, but I finished all the slides. We had 20, right?
Okay.
We went through all of them so far.
Okay.
So I haven't missed any slides. I think I covered the material faster than I expected. I thought it would take longer. Sometimes I over talk, but I like to have more audience participation if possible.
So we have that brings us to the end of this PPT presentation. So I'll request the audience here. Yeah, we can see you now.
Okay.
Are you able to
Good.
see us? Can you see?
Yeah, I have been able all along.
Okay.
No problem.
Okay. So I'll just request the participants here, if anybody wants to make any general comment on what we did here and what we are intending to do. Any general comments? My friend Dr. Sagar wants to ask you, what are the legal issues which you deal generally with when you are doing Teletriage? And I think I'll add to it, what are the legal things which you are guided by? Because in India we are not yet we don't have any telemedicine guideline as yet working here, so we try to borrow from this law and that law, and we don't have anything specific for our field of work, what we intend to do. So how do you do it there? What is the framework you have there?
Well, it all derives from legal tradition related to medicine and nursing, and it goes back to slide number 10, the standards of care. And we have a legal duty to the patient to behave in, and we call that the duty of due care, to behave in a reasonable, prudent way so that no harm is done. And so the reasonable, prudent thing to do is to do an adequate assessment, to use guidelines, to advise the patient in a clear way, and to get their informed consent to the care that we're recommending. So the standard is very broad. The care is, but that is what we use here in the United States. The second thing is when to consult on a case, like I said, have policies and procedures. Do you have a documentation of the call? So all of that I ask for. And as far as the cases go, many of them are related to a failure to assess and failure to communicate adequately. And both patients were it caused a delay in care or a delay in treatment or a delay in diagnosis. So those are cases where the nurse or the physician doing the job failed to do a reasonable, prudent job. The most prudent thing is this, it's kind of a rule of thumb that I recommend, is when in doubt, err on the side of caution. So that's something that you can give to a new practitioner who isn't very secure about making decisions, and you can tell them that, okay, so you're not as confident, you're not as good at this, you're still needing experience, but when in doubt, err on the side of caution and bring them in. The downside of that is what we call overutilization. So then you run the risk of having too many people coming to the emergency room or urgent care or the clinic, and it can cause overcrowding. But the upside is that they're on site, they're safe, and they will be seen in a timely way, even though they may not needed to have been seen. They're at least the nurse has erred on the side of caution, so they brought them in, and they will be evaluated. Does that make sense?
Yeah, that makes sense, and that's probably the
Okay.
guiding principle of any medical practice, and that is
Yeah.
implies here also. Another very
Did they-
relevant question
I-
has come from our professor from surgery. Sir wants to ask, how do you avoid spam calls? Because in our practice also we have found that that really becomes an issue here. When you have a same caller calling again and again, and then you have to make police complaints, and then that sometimes becomes obscene, and it's really difficult. I mean, is there any specific way you deal with, or is there how do you deal with it?
Well, there are different kinds of spam calls. We call them frequent flyers here in the States. And, there are people that are drug seeking, and they're one kind of frequent flyer or spam caller. There are people who are mentally ill, and that's a different kind. There are people who are overly anxious, and that's a different kind. So for the drug-seeking people, they need to be counseled. They need to be brought in at some point if that's the reason for their call. For those that are mentally ill, they need to be dealt with in another way and given a hotline to call, if there is such a thing, or a counselor to call, because we should not be dealing with anything but truly symptom-based calls is the world of telephone triage. So anything that is not symptom-based, a genuine mental or emotional or physical symptom, those are things that fall into our work world. Those are appropriate. And if somebody is suicidal, then we definitely have to help them. And if you have no suicide prevention, you cannot recommend that they call there or transfer the call to them. You have to take that call. People who are calling for prescription refills, they should have a separate line to call. People who are calling for instructions on how to reach the hospital, they should have a separate call line for that. I try to get facilities to pre-triage the calls using a phone tree with voicemail. So non-urgent, non-clinical message to the doctor should go into the voicemail box. Pharmacy refills should go to the pharmacy number. Each one should have its own, in the phone tree, they should all be a different number. But the point is that the first place that people should reach should not be the advice nurse or the clinical symptom-based calls, because then it becomes the dumping ground for everything. So I say pre-triage, educate, if you can, educate the patient on how to use the system, and tell them, if you have emotional problems, call this number. Do you have such a thing as an emotional suicide hotline of any kind there, or is there such a thing, or no?
We do have medical helplines here, but not much used, I suppose. But there are but there are common helplines like the Chief Minister's helpline, and then there are medical helplines. But their utilization is always, I mean, it's not very transparent, and we are not very clear as to how much is the utilization.
So these are for other kinds of calls that could be considered inappropriate or even spam calls for the call center that you're trying to establish.
Miss Wheel,
So I would, excuse me.
sorry for interrupting. I'll just transfer. I mean, I'll just give the mic to my colleague from head and neck surgery. He wants to ask a question.
Okay.
My first question is that what's the status of Teletriage vis-a-vis the normal traditional hospital-based triage, and how much years
I'm sorry, what is the status of teletriage vis-a-vis the what?
vis-a-vis the traditional hospital-based triage?
I'm so sorry, I didn't understand that last phrase.
The hospital traditional hospital conventional way of triaging, that is face-to-face
Oh,
triage.
triaging, what is the status of telephone triage vis-a-vis face-to-face triage in the hospital? Well, we're trying to go in the direction of what's happening in the hospital or the emergency room. In other words, 5-tier triage is what they use in the emergency room for face-to-face triage. And I am a believer that we need to have a similar system for telephone triage so that we also have a 5-tier triage. I have had a 5-tier triage ever since 1995. That's the system that I've always used based on the recommendations of the experts that I use to create the guidelines that you have in front of you. So does that answer your question?
Yeah.
That's the direction. Is the 5-tier triage is the direction that emergency rooms are going in, and I believe that 5-tier triage also applies to telephone triage with some modifications.
My another question is that like we will be starting it very soon, and it's a new area for us. With your experience, what are the positive reinforcements and the negative reinforcements during the different phases of how we evolve on teletriage? Like how we keep ourselves on the other people in the team motivated.
While you're during the process of developing guidelines, or during the process of running
Both.
the call center? Both.
It's more for running, during the running.
Okay. Well, this is, like I said, this is pioneering work, so you have to be patient with yourself. When you're developing the guidelines, it's really important that someone with the vision be leading in a pretty strong way and training those who are going to be doing the work and trying to remain consistent. That's the hardest part, is to create a system that can be consistent for most situations. It took us 2 long years to develop those protocols. And even then, as you see, we still have some things we need to fix. It required a lot of blood, sweat, and tears, and people get discouraged, get burned out. It's a hard task. So you need a strong leader, you need a strong vision, and you need a strong template. You have that if you want it. You don't have to use anything that I've told you today, of course. You can start from scratch. But I can tell you this is a very labor-intensive task. To take everything from the Merck manual and put it into a short, sweet working tool is a huge undertaking, but it can be done. As far as running the call center, I require that the nurses that do this work have at least 3 to 5 years experience. that they be inquisitive. That is the most important quality of the advice nurse. They must be inquisitive. If they're not going to be very good at this work. And by that I mean they have to really be curious, ask a lot of questions, and be interested in really getting to the bottom of the problem. You need a system. You need all of the things that I mentioned, those 5 elements. You need training, you need experienced staff, you need guidelines. You don't have to have hundreds, but you should have a basic set. You need some standards or policies, and you need a documentation method.
Hi.
You'll look a lot better if you go to court, if you have some or all of those elements in a fairly good quality. You will look a lot better to a judge and jury than you would if you had nothing.
Yeah. One last question, please. Do you record all the voice calls, and what's your call on that? Should we or shouldn't we?
Well, I don't have a call center. I'm just a consultant. So I know that Kaiser likes to record all calls, and they do. And you will see a transcript. They have transcripts of all the calls that come in, and I can read those and I can listen to the call when I do my expert consulting. So I think it's a good idea because it has a tendency to create a quality of encounter. I think it raises the quality of the encounter if the nurse knows that she or he is being audio taped, and it provides a record of the call. So you cannot deny what went on when you have an audio tape of it. So I think it's a good idea if you can do it, but I also think it's a good idea to document as well. Both.
Yeah, and just to follow up of that, if we are recording something, I think we need to inform. There's an ethical issue also there because you need to inform the patient in advance that you're going to record the call. And
Yes.
the other thing is, how long do you maintain that record? How long do you store that record? Because now we are just starting, we are in the infancy, but as you said that you've reached the adolescent phase, so over a period of time the records will keep piling up. So how is there a ruling or something, the maximum time that you need to keep the record stored?
I don't know what that is. I think it's 7 years, but it's probably longer. With all the technology that we have now, I think it's probably not impossible to save things fairly easily. But I would check with your Telemedicine Centre legal counsel and ask them what is the law in India, because I don't know what it is for you all. And the technology part I cannot answer, but I think that there are IT people that can tell you how easy it is to save and retrieve calls. And with the technology that we have nowadays, I think it must be fairly easy, but I don't know the answer.
Okay. I mean, is there any, what my professor wants to ask is, do you use any kind of video communication while you are doing triaging in using
No.
social media or something?
No.
So I think it's 8:30 here. So you are at probably 8:05 there in the morning.
Right?
And
Yes.
and it's time to wind up, I think, if there's no more question. Any more questions to be asked? Miss Wheeler, the participants are eager to know whether you have any questions regarding what regarding anything here. From the audience, if you want to ask something.
What do you think your biggest problem will be in the future in this process? Let's say in developing the guidelines, what do you anticipate will be the hardest part?
I have my answers, but I think I'll take the advice of my seniors sitting here. They can guide me better. So I'll hand over the mic to my professor here, Professor Arun Kongnehil. I think I'll take his advice. So what do you think will be the problematic things here?
I think keeping team motivated, that will be the more challenging task. It's going to be, because building up the team and keeping team motivated always for the devoting their works and their time also, that's going to be really challenging, especially in the institute which is in developing phase, and institute where there is already scarcity of manpower and other issues also. So I think this is a major challenge I'm looking at.
If we start suing the teleconsultant which is not in our usual job chart, then why should I do a teleconsultation at all?
Can you repeat that? If you start to be a teleconsultant,
if somebody starts sue or legally challenge a teleconsultant, why should the consultant will ever take up the teleconsultation which is not in my usual job chart?
okay. I have a big old disclaimer in my guidelines. If you look in my adult guidelines at the front, everybody who develops guidelines has a disclaimer that says, we did the best we could with the information that we had. And, medicine and science is a changing field. The user is advised to use these in a reasonable, prudent way. Since 1995, no one has ever approached me with a lawsuit. And I can tell you that I've consulted on a lot of other guidelines who have been approached with lawsuits. So the point I'm trying to make is, I think books are safer than software. They're more transparent. And I think that you can only do what is reasonable and prudent as a developer of guidelines, and then you have to let go and say, okay, these are qualified people, they've had some training, and they've been told to use their best judgment. And we do the best we can. And like I said, you can always err on the side of caution if you're worried. So I don't worry too much about being sued. Like I said, it's been since 1995. My guidelines have been out there. No one has ever approached me saying someone was harmed because of what I wrote, and that was because I think we worked so hard to think of everything. We worked so hard to make a lot of rule-outs, checklists, and screens. So does that answer your question? Yeah? I can't hear you, Dr. Halder. There.
Just my last comment that, am I audible now?
Yes.
Yeah. There's no, what I could understand is that there is no shortcut, or there's no cookbook kind of solution to making protocols and then using Teletriage. It's the motivation, it's the diligence, and it's the teamwork which ultimately gives the right outcome. And there's no shortcut, in very short. I'll just recapitulate what we discussed here, just a few lines. We discussed about...
Now move again.
Sorry, anything you want to add? Sorry, Miss Wheeler, that
That's
just
what
went off. The last words. Thank you so much. On
Likewise.
behalf of my all colleagues and my technical team here, I am really thankful that you conducted this workshop. I mean, this seminar for us, and I am sure that this will take us to where we really want to go, and we'll work hard, and we expect that you'll keep your support, giving support to us, and we'll really.
Yes.
We are looking forward to you for more inputs and more expert help. Thank you so much, and we really appreciate your inputs.
And thank you for your attention and for honoring me with this opportunity. I really appreciate it, and I wish you great luck with all your hard work.
Thank you, Miss Wheeler. Really, thanks.
Have a great weekend.
Good afternoon. Good morning.
Okay. Bye-bye.